Tēnā katoa, tēnā katoa, tēnā katoa, katoa. Kia ora everyone, good evening. It's a great pleasure to be here and thank you for that introduction. What I'd like to do tonight is give you a bit of a range of research topics that I've been involved with over the last 40 years or so, and really trying to illustrate the unexpected nature of clinical research. And in doing that, I really want to stress from the outset that I've always worked as part of a team, and that in presenting the findings of this research, I really presented on behalf of the colleagues that I've worked with over the years. So I'm going to present 10 different research projects. And the first one is one of the first studies that I was ever involved in when I was doing my postgraduate training in Southampton in the United Kingdom. It was based on a clinical observation that was unexpected, in that I was giving asthmatic volunteers, as part of a research study, a drug called Atrovent, a nebuliser solution, which was commonly used for the emergency treatment of asthma in the emergency department. What was surprising, that although most of the patients got better when I administered the Atrovent nebuliser solution, there were some patients who got worse, and got a lot worse. So this was perplexing, and I can recall going down to the Southampton University Library and trying to delve into this further. There was no internet in those days, and identified that the solution had two preservatives in, one of them called benzalkonium chloride, which is a chemical which releases histamine from mast cells. Histamine is a natural chemical that can provoke not only asthma and hay fever, but also anaphylaxis. The other chemical was used to make dogs asthmatic in animal experiments. And both these preservatives were included in the nebuliser solution for the purpose of ensuring there was no bacterial contamination, because it was included in a big bottle and you get a syringe and you'd pull out the amount you wanted to give to your patients. So we undertook a very simple study of patients who had reacted badly to the Atrovent solution. And we got them in on 3 different days, and we gave them either the Atrovent solution that had the preservatives in it at the bottom, or we gave them a saline, or we gave them Atrovent that was preservative-free. And this is the result. You can see on the y-axis is a thing called the FEV1, which is the lung function. And you can see if we start at the top, when they received the Atrovent preservative-free, they improved, as you would expect with a bronchodilator, and that was the purpose of giving this drug to patients in the emergency department. When they received saline, there was no effect at all. And when they received the Atrovent with the preservatives, the normal solution that was available and in standard use, their lung function got a lot worse very quickly. In fact, the reduction in the lung function was greater in magnitude than the benefit in those patients when they took the Atrovent preservative-free solution. And you could just imagine what would happen in an emergency department when a patient comes in with a severe attack of asthma and they got the Atrovent solution with the preservatives and got a lot worse. The response would be to think how terrible their asthma was getting worse despite the Atrovent, and you'd be given some more. Until there was a real chance that you would then end up with a life-threatening attack of asthma. So we published our results, and within 12 months, the use of preservatives and nebulized solutions stopped. Instead of being produced in a bottle, they were produced in unit dose vials for single use without any preservatives at all. So this was an unexpected clinical observation, but I think the formulation could also be judged as unexpected, because who would put 2 preservatives at an asthma nebulizer solution, each with the potential to provoke asthma to make patients worse? I think the regulatory approval was also unexpected. Clearly, insufficient attention was paid to the data that was presented to the regulatory authorities around the world. And that probably related to presentation of mean data of an average improvement with the nebulizer solution, without looking at the spread of the data and the fact that some patients got worse and that this could lead to a catastrophic outcome in the setting of acute severe asthma. For me, it showed the power of a simple randomized controlled trial that could be done in a couple of months without any specific funding, that could change the formulation of a common asthma medication worldwide within a very short period of time. And for me, this was in some respects, a life-changing event because it made me realize the impact and the importance of clinical research undertaken at the bedside, particularly if it was focused on challenging dogma or current practice, had the real ability to change practice and increase knowledge. Number 9. This is another study that I undertook when I was in Southampton, and it was actually a very simple design. We were wanting to understand the process of airways inflammation in asthma, which is the basic disease process. And so what we did is a bronchoscopy where you slip a wee tube into the lungs and you take a biopsy. And we did this in people with really mild asthma. You could almost call it trivial asthma. And we did the biopsies, and then we gave them allergen to inhale to provoke an inflammatory response, and then we biopsied them again 18 hours later when the inflammatory response was at its greatest. We also biopsied some normal subjects as a control. What we found was most unexpected. The baseline biopsies of these people with trivial asthma were so abnormal with acute and chronic inflammatory changes that we couldn't tell them apart from the biopsies of the same people in the middle of the allergic inflammatory response 18 hours later. And they were grossly abnormal compared to the normal subjects. Trivial mild asthma was thought to be just a disease of twitchy muscles in the airways that would just constrict. And this was the first direct evidence that they were in fact, airways inflammation was an underlying disease process across the spectrum of asthma, not just the moderate and severe patients whom it was recognised in, but also in the mildest forms of the disease. So this had unexpected findings from the study and also unexpected consequences, because the knowledge that all forms of asthma, even the most mild forms of asthma, were associated with this inflammatory process led to a change in the treatment of asthma, where anti-inflammatory drugs with inhaled steroids now became recommended across the full spectrum of asthma severity. So here we have the second study to show you that this knowledge in itself was enough to lead to a paradigm change in asthma management and lead to a marked reduction in the burden of asthma worldwide. Number 8. So I'm going to move away from asthma now, and I'm going to focus on traveller's thrombosis on land. Okay? And we all know that in the 1980s and the 1990s that traveller's thrombosis, or the risk of a DVT, a deep vein thrombosis, or the risk of a pulmonary embolism, a PE, was present in people who travelled for long periods. This was initially termed economy class syndrome, and people recognised that actually other people in the other parts of the plane could get it as well. And then it was called traveller's thrombosis. Now, what intrigued me in my clinical practice was these patients I would see who had no other risk factors for a DVT or PE, but they would sit for incredibly long periods in their work and in recreation. Recreation predominantly being gaming. That they would sit for 12 to 16 hours a day or even more. Staggering, but not uncommon in terms of people working in IT or call centres or people who are really into gaming. Sitting for periods that was not much different really from what you would do if you flew to LA. Not that we fly through LA anymore. And yet it occurred day after day and week after week. So we undertook a series of surveys based on patients admitted in the Wellington region, and we found that the proportion who had seated immobility on land was very similar to the proportion who had long-distance air travel as their risk factor. And then in fact, when you added them all up together, they came to about a third of all cases of DVT, or pulmonary embolism. And we termed this seated immobility thrombosis, or the SIT syndrome, to encompass prolonged sitting and all these different circumstances in which this could occur. And I think it is likely that the SIT syndrome is going to become more and more prominent in our community as prolonged seating becomes more of a lifestyle in terms of both work and recreation. So in some respects, these findings weren't unexpected at all, particularly when we look back to 1940. And this is during the Blitz in the Second World War. And it's quite interesting, there was actually a parliamentary select committee that was concerned about the public health risks of people being forced into air raid shelters in very cramped conditions, whether that would lead to a risk of influenza or pneumonia in terms of the people within the air raid shelters. And so the select committee commissioned the London coroner to do postmortems on all patients or all people who died around the time of being in or just coming out of an air raid shelter. And he didn't find cases of influenza or pneumonia, he found cases of pulmonary embolism. And then he put on his occupational health hat and went down and had a look and found that people were sitting in deck chairs for long periods of time, compressing the veins draining the blood from the legs across the back of the thighs. And so he got the authorities to take the deck chairs out, and he put in mattresses and bunks, continued doing the postmortems, and the problem went away. So this is a case where we had knowledge at one stage, but it hasn't been passed on in terms of more recent times. Number 7. We're now going to the late 1990s when party pills were introduced into New Zealand. And as we may recall, it was mayhem, wasn't it? Okay, particularly in Courtney Place on a Saturday night. And the public health physicians and the Ministry of Health didn't know what to do because there wasn't published evidence of the effects of party pills, and so they didn't know how to classify it. So we undertook a clinical trial with the support of the Ministry of Health. We randomised people who had used party pills before to one of 4 treatments. One with the party pills BZP and TFMPP. For those who were in the game at the time, that was the Jet and the Bliss tablets. We gave the recommended dose. Or we randomised them to the party pills and alcohol, 6 units over 2 hours. Or they got alcohol and the placebo tablets, or they got the placebo tablets and alcohol. And I can tell you there's an awful lot of very thick, pithy orange juice going around to disguise the taste of the alcohol. And what we found, and what we did was we assessed the acute and the long-term physiological and psychological effects and the effect on sleep of these 4 randomised treatments. And we also assessed their driving performance, because the party pills are a bit like a dirty amphetamine, and so there was the expectation it may improve driving performance even if it had other adverse effects. And what we found was, well, in fact, we had to stop the study because we were concerned about the safety of the volunteers who were taking part in the study, due to both the nature of the serious side effects they were experiencing, but also the risk they were putting themselves, or we were putting them at, in terms of driving and using machinery the day after, having not been able to sleep the night after the day in the lab. This information was reported back to the ministry, who classified the drugs as Class C, and they were removed from the market. And the intriguing thing is that if the party film manufacturers had actually undertaken dose-response clinical trials before they had marketed them, they may have well been able to work out an optimal dose where the benefits outweighed the side effects, and they might still have been on the market today. But we don't know that. Oh, and in terms of the driving performance, when the two groups that took the party pills, they improved, the alcohol alone got worse, as might be expected. Number 6. So we've also had a research program led by Sarah Aldington on the effects of cannabis on the lung. And this was quite relevant to New Zealand because New Zealand has one of the highest rates of lung cancer in the world. We have one of the highest rates of asthma and COPD in the world. And we have a high rate of cannabis use, in part due to the fairly relaxed legal situation in terms of use by individuals. But there are a number of good reasons why we might be concerned. The first is that the products of smoking a cannabis joint, the different components are very similar to tobacco, except that tobacco has nicotine and cannabis has THC. The way it's smoked is different. That when you smoke a cannabis joint, you take a bigger breath in, you hold it for longer. And in fact, if you get someone to smoke both a joint and a normal cigarette in their normal way, is both the same size, after smoking a joint, you'll get 5 times the amount of carbon monoxide in your blood than smoking the cigarette. And also, cannabis smoke has a higher level of polyaromatic hydrocarbons, which are highly carcinogenic. So it was surprising to us in a way when we started to read the background literature that there was very little information on the effect of cannabis on the lungs. What I want to show you here is the study results in terms of the effect of lung cancer and the risk of lung cancer. We did a national case control study of people who developed lung cancer under the age of 55. And we matched them off the electoral roll with 4 individuals who did not have lung cancer. And we found that indeed cannabis smoking did increase the risk of lung cancer. 1 joint a year, which is 1 joint per day for 1 year, increased your risk of lung cancer by about 8% after adjusting for tobacco smoking. 1 cannabis joint was equal in risk of lung cancer, about the same as 20 cigarettes, and that's a very crude estimate. And the earlier you started smoking cannabis, even matched for the amount, you had a greater risk of lung cancer. And this thing we call the population attributable risk of lung cancer due to cannabis smoking was about 5%. So this study provides data, New Zealand data, for the first time on which public health information and education campaigns can be based, providing a scientific basis by which tobacco cessation programs can include cannabis smoking. And this is important so the person who is considering or is smoking cannabis, they have the knowledge to make a decision as to whether they want to take that risk or not. Number 5. This is a landmark study that was funded by the Health Research Council of New Zealand on the treatment of a pneumothorax, which is a collapsed lung, where the lung just tears and collapses down, often in otherwise young, healthy, tall, fit men. It's really quite a major public health burden. It can cause distress, particularly when a doctor comes along and shoves a big tube into their lungs, admits them to hospital, and many of them have to subsequently go to surgery. Now it's quite interesting when you go back 50 years and read the case reports of pneumothoraces. It was very clear that the majority of people didn't need any intervention at all before there was an intervention you could offer. But the interventional approach became a fashion, and then it became a standard of care. And a bit part of this thing that, oh, well, you've got to do something for a person with a major health problem. So we undertook a randomized controlled trial. We randomized people presenting to EDs in both Australia and New Zealand to either what we called watchful waiting, where we would observe them. If they were stable, we let them go home. If there was any deterioration in their condition, they would come back and have a tube put in place. Or they had what was standard care, which was the interventional approach right from the start in terms of intercostal drain. And these were people who had had a big, almost complete collapse of the lungs. And what we found was that 7 out of 8 people did not need an intervention at all. In fact, probably many of those who did get an intervention probably didn't need it either. And that by watchful waiting, they had a far lower risk of serious adverse events, prolonged admission to hospital, a lower rate of surgery, they got back to work quicker, and they had a 50% lower risk of a recurrence in the next year. So this study changed practice worldwide essentially overnight, and became a change in the standard of care that was safer, more effective, better for the patients, and avoided the harm from unnecessary intervention in those who did not require it. So it was interesting, just as an aside, when we started the study took us 6 years to do, okay? They take a while, some of these clinical trials. We had real trouble getting EDs around New Zealand and Australia to take part in the study because the view was that it was unethical, because we knew, didn't we? We all knew that intervention was better, that's why it was the treatment. And it would be unethical to give someone a watchful waiting approach when we knew the answer. But the randomized controlled trials had never been done, and there wasn't evidence on which to decide who would or who would not need an interventional approach. And so that brings us back to the let's first do no harm. And it is a concern that there are many interventions that are currently in standard practice that have not been assessed. They're often based on a really good idea, but they have not been assessed in terms of any scientific scrutiny to determine whether they are better than the alternative forms of treatment and should in fact be in clinical practice. Number 4. So for those who can read the fine print, acetaminophen is paracetamol. And it's interesting, the treatment of fever is standard practice throughout New Zealand and globally. Paracetamol is one of the most widely used drugs ever given to man. Which at one level is quite surprising, because fever is a protective, evolutionary, physiological response that is beneficial to patients when they are ill. It has evolved over thousands and thousands of years, and if it was harmful, it would have been dropped out along the way. And that almost every study in animals, no matter what the animal was, where you prevent the animal from mounting a fever in the setting of a severe infection, that when you treat the fever, the animal is more likely to die. Okay, and that's very strong evidence across many different animal species. So we thought it was worth a look in terms of critically ill patients. So we did a study supported by the Health Research Council of New Zealand, where we randomised critically ill patients with fever due to an infection to either high-dose intravenous paracetamol, which was standard practice, or placebo. And we followed them for 90 days. Death was the primary outcome. And what we found, there was no difference in the outcome over 90 days between those who received paracetamol and those who received placebo. So we could look at that in different ways, I suppose, couldn't we? We could say, well, thank goodness it hasn't caused any harm. We could say, well, why have we given a drug as standard practice for 100 years for fever when there's no evidence, at least in this study, of benefit? Unfortunately, there was very little difference in effect on fever with the paracetamol that was used, about 0.3 of a degree Celsius. So we weren't really able to even answer the question in the study whether a change in the temperature can affect outcome in critically ill patients. So that was frustrating in a way. So we've now pivoted in this program, and we're now working together with Fisher & Paykel Healthcare with a therapy called rhinotherapy, where you inhale humid, heated air to the airways where the infection may lie to try to prevent the infection from progressing. Because most respiratory viruses and bacteria cannot thrive at temperatures within the physiological range of around 39 to 40 degrees. It'd be fair to say that there's been slow but steady progress, and we're still working on that as a therapeutic approach. But this does sort of broaden the question, not just relating to fever, but how much should we actually interfere with other basic physiological functions in critically ill patients? How much and what type of fluid should we give them? What nutrition and what type of nutrition and how many calories should we give to a critically ill patient? How much oxygen should we give? This is a core inquiry from the intensive care unit group at the Institute, run by Paul Young. And he's methodically going through each of these questions as it relates to critically ill patients to try to resolve some of the uncertainty in terms of the best therapeutic response. So let's turn now to number 3, which is our randomised controlled trial, also funded by the Health Research Council of New Zealand, looking at conservative oxygen therapy in patients who are critically ill receiving life support in the intensive care. This is a study run by Di Mackle and Paul Young, and what they did is they randomised patients admitted to intensive care to either conservative oxygen, which is just enough oxygen to keep a patient within the physiological range, which is the range that we would have here in the room tonight, or liberal oxygen, which is the standard of care, which was any critical patient would receive high flow oxygen regardless of need or response. So this was challenging the current practice in terms of oxygen therapy. This is the survival curve, very similar to the previous one I showed you, showing that there is no difference in the overall group of patients admitted to intensive care with conservative versus usual oxygen. We suspected this might be the case, and we were not sure of the clinical implications at the time, except that we published this the week before the WHO announced the COVID pandemic. And as you're all aware, there was a critical crisis of a lack of oxygen supply within many countries, including Western countries, due to the demand of oxygen therapy with sick patients. This study provided the evidence that it was safe to give a conservative oxygen approach where you just got the oxygen to the level of what is a normal physiological level, and it averted or lessened the crisis that otherwise occurred in many countries. And so in some respects, the impact of this study was unexpected in terms of a sort of pandemic proportions. And it has really changed the way people use oxygen within the intensive care unit. So it allowed the conservative use of oxygen to be implemented worldwide during the COVID pandemic and promoted the efficient use of a limited resource. So where's Paul going from here? He's just about to complete the largest study ever undertaken in intensive care 40,000 patients. I just forgot the number for a second. Okay, and he's going really well. He's doing the study in 16 countries, and they've only got about another couple of months to go. What he's planning to do with that study is to make it big enough so that he can see whether there are differences in terms of what is optimal for oxygen therapy in different groups of patients. And there are reasons to think they might be different. So if you, in the intensive care, having been resuscitated from a cardiac arrest, it may be that you need very little oxygen, because if you give too much oxygen, you get a greater reperfusion injury, which can cause harm. It may be a patient in the bed next door who has sepsis, that they may need more oxygen to increase the tissue supply of oxygen to help fight the infection. So what he's hoping to do is to see whether within the overall no difference in patients in intensive care, are there some groups who do better with one form of treatment and others do better with another. And then what he's going to do, he's going to take that data and do machine learning to see if you put the diagnosis and other characteristics of the patients into a model, you can do what's the holy grail of medicine, which is personalized medicine. And you can work out for each individual patient which is the oxygen regime that is best suited for you. And so this is a program that's been going on for about 10, 15 years, and we think it's probably got another 5 or 10 years to go, certainly in terms of what we're hoping to achieve. Right, now for the last two, I want to turn back to asthma. And I want to go back to asthma as an inflammatory disease of the airways, of which the standard treatment has been maintenance and inhaled corticosteroids taken on a regular scheduled basis. Now there are two problems with this. The first is that most patients with asthma do not take their inhaled steroids most of the time. Okay? And that's just a fact, despite everyone's best efforts, including the patients. The other is that asthma is a disease that comes and goes and gets better and worse, and the inflammation gets worse and it gets better. And so you really need a way where you can actually titrate the amount of inhaled steroid you take, so when the asthma gets worse, you end up taking more to prevent it becoming a severe life-threatening attack. And this led to what was being called the 2-in-1 inhaler, where you put the inhaled steroid in with the reliever, and when you take your reliever and you take more and more of it in a worsening attack, you're getting more and more of the preventer. So the concept is actually really simple, and I think it's deeply disappointing that the medical profession has taken so long to recognize that this probably is the best way of using both the reliever and the inhaled corticosteroid drug. So we've been really fortunate with the support of the Health Research Council to undertake 3 of the landmark studies that have contributed to the evidence in adolescents and adults. This is a graph showing the 3 studies, from mild on the left to severe on the right, and the risk of a severe exacerbation on the y-axis, where the 1.0 is no difference at all. And you can see that no matter whether it was in mild or in severe asthma, that the 2-in-1 inhaler used as a reliever reduced the risk of a severe exacerbation in some populations by over 50%. And that is a dramatic effect in terms of asthma treatments. And so these studies have contributed to the body of evidence on which national and international guidelines now recommend that the 2-in-1 inhaler is the preferred reliever for asthma in adolescents and adults across the range of asthma severity, rather than the old salbutamol blue inhaler that was the standard of care for a very long time. Now, we've been really lucky in New Zealand in that we have the Asthma and Respiratory Foundation, who is so proactive in getting a guidelines group together and also promoting this recommendation of the 2-in-1 inhaler. That has led to a more than 2-fold increase over this 5-year period in the use of the 2-in-1 inhaler, and that has been associated with a 23% reduction in hospital admissions in non-Maori and a very welcome 32% reduction in Maori. Remember, there's gross inequity in terms of healthcare outcomes in New Zealand, and so this is a very reassuring finding. Particularly when we think over the same period of time, there was an increase in hospital admissions due to COPD, the related disorder in adults, and in pneumonia, and in children in asthma where this regime is not recommended. So let's give some thought to children. For far too long, children have been neglected in clinical research, and this includes asthma. So there's only been one study with insufficient evidence to allow a recommendation for the 2-in-1 inhaler regime in children. So with the support of the Health Research Council, Cure Kids and Perpetual Guardian, we have now undertaken the CARE study, which looks at this regime in children, and it will be published in The Lancet later in September. And together with Stuart Dalzell in Auckland, we have 3 other studies on the run, each complementing each other across the severity of asthma in children, and we hope within a couple of years we'll have provided the evidence that is required to determine the optimal treatment for asthma in children, whatever that should be. And in terms of mentioning these studies, I want to particularly acknowledge 2 people. One is Mark Weatherall, who is from the University of Otago, who is our biostatistician who designs and analyses our studies. And the other is Mark Holliday, who's the person who manages the studies on the ground. It's a real team effort in terms of this clinical trial program. Okay, number 1. We have to go back now 40 years to a period when New Zealand had an asthma mortality epidemic. I'd just come back from Southampton, having done my postgraduate study there, and New Zealand was in the midst of an epidemic of asthma deaths, where our death rate was higher than any other country recorded in the world. It had increased dramatically in the mid-1970s, and it followed an epidemic of deaths 10 years earlier that was attributed to the use of a particular high-dose, potent, non-specific beta agonist called isoprelin. So a task force had been commissioned to survey the asthma deaths and had been unable to find a cause and had not addressed the possibility that may relate to one of the medications. So a group of us formed the Wellington Asthma Research Group, and we set about trying to investigate the cause of the epidemic of deaths, and we started by looking at medications. And we did a comprehensive series of epidemiological and experimental studies that identified that a beta agonist drug called phenotyrol, or Beratec, was the likely cause of the epidemic. This is through a series of case control studies undertaken in New Zealand. The risk was up to 10-fold. The risk of death was up to 10-fold in certain high-risk groups. Our findings were subsequently confirmed by similar studies in Canada, Germany, Japan, and South Africa. There's probably a dose-response relationship evident in these studies, and it was biologically plausible because phenotyrol had greater acute and chronic adverse effects that were greater than the other commonly used drug of salbutamol and were very similar to isoprelin forte. Of course, we had the analogy of the epidemic that had occurred 10 years earlier, and there was ecological evidence in that the sales of phenotyrol at first became available in New Zealand the year the epidemic started, and in the 3 years it achieved 30% of the market share. Asthma mortality had increased by 2-fold. We had the highest use of phenotyrol of any country in the world per capita. So the Minister of Health, who was Helen Clark at the time, she decided to remove phenotyrol from the drug tariff, which effectively removed it from the use in New Zealand. And this was associated with a dramatic 2/3 reduction in asthma deaths in New Zealand and it has fallen progressively since then due to other improvements in management. This was a great outcome for New Zealand, but it was also a great outcome for asthma management globally, because it really pinned down the risks of high-dose potent bronchodilators and treatment dominated by the reliever form of therapy, as opposed to the anti-inflammatory treatment, which turns off the disease process and reduces the risk of death and the burden of asthma. Now, some people ask, well, were these findings unexpected? How did we work this out? The findings were not unexpected at all. We had really quite substantive evidence by the time we came along that there may well be a problem with phenolphthalein. We had the very strong analogy with isoprene forte, and that phenolphthalein was very similar to isoprene forte in terms of its pharmacology and the adverse effects. And there was already starting to come out evidence from cohort studies of people who had died, that more people died on phenolphthalein than might have been expected in terms of the national sales. So what we did, we filled in some of the gaps. So we did the case control studies, which are the heart or the core of the evidence, and it's a bit like a epidemiological version of a randomized controlled trial. Because of course you can't do a randomized controlled trial of death from a drug like for asthma, because you'd need the entire country to be involved, have the power to determine an effect. We were able to extend the pharmacological evidence, we developed the ecological evidence, and we determined the strength of the association. And then subsequently, and very importantly, our findings were replicated by other groups, and that's always really important in the scientific field, that other groups replicate your findings, and also filled in some of the other gaps in the jigsaw. We were really fortunate that we had a multidisciplinary team of researchers leading the Wellington Asthma Research Group. And if we go from right to left, that's Carl Burgess on the right, who's a clinical pharmacologist, Neil Pearce, who's an epidemiologist, Julian Crane, who's a respiratory physician and a public health physician. And this was at a function held sometime later, commemorating the findings and the impact in New Zealand with a painting that was hung in the University of Otago Wellington School Library. But that really comes back to the beginning of my talk, to conclude by saying that I've been incredibly fortunate over the years to work with such talented and committed people throughout my research career. And the results and the findings I've shown you today has really been the result of a massive team effort. I've also been extremely fortunate to have had such institutional support, particularly from the Medical Research Institute of New Zealand over the last 25 years. Wellington Regional Hospital has been a real star. More recently, Victoria University of Wellington, and also Southampton University in the UK. I think in terms of clinical research, the other thing that we're really fortunate in New Zealand is that we work and live in a community that is so generous and altruistic. There have literally been tens of thousands of adults and children who have participated in our research studies over the years. A relationship built, I think, on mutual respect and trust, and it has allowed us to undertake studies that would otherwise not have been possible if that trust did not exist. As you've heard through some of my projects, I've had support from the Health Research Council of New Zealand throughout my career, and that has been incredibly valuable. I think I'll leave it there, but perhaps thank the Royal Society for the acknowledgement with the award and for organising tonight. Ngā mihi nui.